You're walking into your patient's room for the very first time that shift. IV pumps are flashing, monitors are beeping, and right in the middle of it all is the one device that makes your stomach do a little flip: the central line. It is stitched right into their chest or neck, and you know a mistake here carries massive consequences. You don't need to be terrified of these lines. We're going to bridge the gap between the textbook facts you memorized for the NCLEX and the practical decisions you actually have to make during a shift. Think of the vascular system like a map. A standard peripheral IV in the hand is a local road. It is small, delicate, and handles light traffic. This animated diagram shows why. Look at the left side. Blood flow in a hand vein is a slow 40 milliliters per minute. Now look at the right side. A central vein is the interstate highway, rushing at roughly 2,000 milliliters per minute. What confuses newer nurses is the word central. You might see a PICC line starting in a patient's bicep and automatically file it under peripheral. But watch this pathway track internally. The line threads all the way up the arm, through the shoulder, and drops right down to terminate at the cavioatrial junction, right at the entrance to the right atrium of the heart. The destination, not the entry point on the skin, is what makes it central. Because that tip sits in a massive, turbulent river of blood, it instantly dilutes harsh, highly acidic medications like vancomycin or total parenteral nutrition that would rapidly burn a small hand vein. But that direct-to-the-heart efficiency works both ways. It easily delivers medication, and it can easily deliver a fatal complication. The absolute biggest bedside threat is a central line-associated bloodstream infection, or CLABSI. We aren't talking about a red, itchy spot on the skin. Bacteria form biofilms inside the plastic catheter and dump directly into the patient's bloodstream, causing a systemic, life-threatening, hospital-acquired infection. To prevent this, hospitals enforce strict, maximal sterile barrier bundles. Think of these bundles like a precise baking recipe. You cannot just pick and choose the ingredients. If you skip the sterile gown or let the patient cough without a mask during insertion, the entire system is compromised. Take the skin prep. This microscopic cross-section shows the physical mechanics of a chlorhexidine scrub. You can't just gently paint the liquid over the site. You must use aggressive friction for at least 15 seconds, physically forcing the antiseptic down into the microscopic crevices of the skin layer. But here is where rushed nurses make a massive error. You complete a perfect, aggressive, sterile scrub, and then to speed up the drying time, you lean over and blow on it. Instantly, you introduce a cloud of respiratory bacteria straight onto the sterile field. Fanning a sterile package over the site does the exact same thing with room dust. Patience is a required physical barrier here. The chemical bond of the chlorhexidine relies absolutely on undisturbed natural air evaporation to work. You have to let it air dry completely on its own. Once the line is perfectly clean and secured, you face the daily maintenance, and eventually you will encounter the dreaded brick wall. You attach your normal saline flush, pull back for a blood return, and try to push, only to meet solid, unmoving resistance. Your instinct might be to just push a little harder to clear the jam. This physics comparison shows exactly why that is incredibly dangerous. A narrow 3 milliliter syringe barrel generates massive, highly concentrated pounds per square inch. If you apply force, you can physically rupture the plastic catheter inside the patient's chest. A wider 10 milliliter syringe distributes that force safely, acting as a built-in safety valve. If the line won't flush, you have to play detective. If blood backed up and clotted, you need a physician order for a fibrinolytic medication to dissolve the biology. If two incompatible IV drugs met in the tubing and formed solid chalk crystals, you need a pharmacist to mix a highly diluted acid to fix the chemistry. But what if the problem is purely mechanical? This diagram demonstrates pinch-off syndrome, where a subclavian catheter gets literally crushed between the patient's collarbone and their first rib. So before you start ordering clot busters or acidic solvents, what physical bedside action should you ask the patient to perform? Just ask them to raise their arm. Elevating the arm lifts the collarbone directly off the first rib, unkinking the catheter so the flush glides right through. Understanding human anatomy solves the problem instantly without risking a single drop of chemical intervention. Blockages are stressful, but an open line is lethal. The chest operates on negative pressure. When a patient inhales, their chest expands to create a vacuum. If a central line hub is left open to the room, maybe a cap falls off or you forget to clamp it during a tubing change, that exact same vacuum sucks room air directly into the bloodstream. You will see the effects explosively at the bedside. Sudden severe chest pain. They start gasping for air. Their blood pressure crashes and they rapidly become confused as the heart churns that air bubble into a frothy lock, starving the lungs and brain of oxygen. The absolute first reflex you must have the second you see these signs is to clamp the line. Halt the influx of air immediately. Next, you execute a highly specific physical maneuver. You place the patient in the left lateral decubitus position and Trendelenburg. As shown in the schematic, you roll them completely flat onto their left side and tilt the entire bed so their head is significantly lower than their feet. This leverages the literal physics of buoyancy. Air is lighter than blood, so the bubble will naturally float to the highest possible point. By angling the body this way, you position the right atrium higher than the exit pathway to the lungs. The air bubble becomes safely trapped against the chamber wall, preventing it from being pumped forward and causing a massive stroke or cardiac arrest. Surviving an emergency is great, but routine vigilance prevents them entirely. Every single shift, you need to read the centimeter markings printed directly on the external catheter. If the line was inserted at 1 centimeter, and today it sits at 5 centimeters, the internal tip has migrated. It might now be resting in a delicate vein that will rupture if you infuse chemotherapy through it. For PICC lines, measuring the mid-arm circumference is just as crucial. A sudden 3-centimeter swelling of the bicep indicates a silent deep vein thrombosis is likely forming around the plastic tube. The absolute best way to manage central line complications is to get rid of the line before the complication happens. Every single day during rounds, ask the provider if the patient still needs the device. Master these 5 tactical rules. The destination makes it central. Let the chlorhexidine air dry undisturbed. Only use 10 milliliter syringes for flushing. If you hit a mechanical pinch off, raise the arm. And if you suspect an air embolism, clamp the line and roll the patient to the left. If your patient is awake, eating, and off harsh IV medications, advocate for that line to be removed. Do not leave it in just because it makes blood draws more convenient. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.